Miss Smith? I'm going to try sternal rub. Miss Smith? She's not responding. I can't feel a pulse. Robin, go ahead and push the code button. Alexa, I'm going to have you take the backboard off and I'm going to drop the bed. Let's go ahead and tilt her and we're going to begin chest compressions. Robin, will you please back the patient? Let's go ahead and get the AED pads on and I'm going to displace the uterus. When a maternal code is called, there are several additional teams that need to be called in for help. Those include additional nursing staff, NICU, ICU, anesthesia, and maternal fetal medicine. She's in pulseless electrical activity. During a maternal code, there are several additional considerations with ACLS that need to be considered. 1. Start chest compressions. 2. Displace the uterus in a left lateral tilt or by manual displacement to improve venous return. However, manual displacement is preferred to perform effective CPR. 3. Perform chest compressions higher on the sternum due to gravid uterus pushing abdominal contents and diaphragm and thus the heart upwards. 4. Quick assessment of gestational age. If greater than 20 weeks, begin thinking about resuscitative hysterotomy regardless of viability. 5. Follow the same ACLS guidelines as you would with a non-pregnant patient, as any potential risks to baby are outweighed by benefit to the mother. 6. Fetal monitoring is not recommended during the resuscitation process.
Hey, what's going on?
This is Miss Smith. She's a 30-year-old G2P1 at 38 weeks, history of AFib. She was noted to be unresponsive with no pulse, so we've started chest compressions and we're preparing to intubate.
Hold compressions.
How long have you been doing compressions?
Almost 2 minutes.
Okay, let's be prepared with Epi at the 2-minute mark if she doesn't have a pulse.
Agree. What are we suspecting is the cause of her arrest?
We suspect an amniotic fluid embolism, but we can't rule out other causes of a maternal code.
The most common causes of maternal code include hemorrhage, cardiovascular events, amniotic fluid embolism, magnesium toxicity, pulmonary embolism, arrhythmia, heart failure, sepsis, preeclampsia, endocrine emergencies, or trauma. Yes, I agree. AFE sounds highly likely. Have we considered a bedside hysterotomy?
We can consider a hysterotomy if the patient is not resuscitated after 4 minutes or 2 rounds of CPR. We'll consider it at that point.
Bedside hysterotomy should be considered during maternal cardiovascular resuscitation in patients with an estimated gestational age greater than 20 weeks. This is performed for maternal benefit to improve venous return by relieving compression on the IVC. The only instrument needed is a scalpel, and the incision can be fan and steel or vertical per the provider's discretion. This should be performed regardless of viability because remember, this is for maternal benefit.
Shouldn't we go to the operating room for the hysterotomy?
No, we never go to the OR when CPR is in progress. A bedside hysterotomy should always be performed here at bedside during maternal resuscitation.
I've got a scalpel. Let's get the hemorrhage part.
It's been 4 minutes.
Let's check for a pulse.
She has no pulse.
I'm going to proceed with hysterotomy.
The team performing chest compressions continues while the hysterotomy is made. The baby is handed off to the awaiting NICU staff. The uterus is then reapproximated for hemostasis and the abdomen is packed.
It's been 2 minutes. I'm checking for pulse. She has a pulse. She's in normal sinus rhythm.
Let's anticipate a hemorrhage. Go ahead and start the massive transfusion protocol and let's move to the OR.
In every obstetric emergency, a debrief should be performed with the team discussing first what went well, what could have gone better, and what we would do differently next time. The debrief is also an opportunity to confirm details of the code with the team members to help with consistency and documentation of the event.